Good afternoon, everyone, and welcome to today's webinar hosted by PYA, Getting Online with Telehealth, Practical Guidance for Physician Practices. PYA is a leading professional services firm providing expertise in healthcare, tax, management consulting, and audit and assurance. We are pleased to offer you our thought leadership on this important topic. All attendees have been placed in listen-only mode. You may submit written questions using the question pane of the control panel. Our presenters will address as many questions as possible during the Q&A session at the end of the webinar. If we cannot answer all questions due to time limitations, we will supplement the transcript to this webinar with written responses. Please be aware, with more people using online platform, outages can occur. Should the webinar be paused, we will work to restore it as quickly as possible, and all of our webinars are recorded and released after the event. With that, I would like to introduce our presenters, Marty Ross, Valerie Rock, Barry Mathis, and Kathy Greenlee.
Thanks, Laura. Hi, this is Marty Ross with PYA. Good afternoon, everyone. Thank you for joining us this afternoon. It has been a busy week, and we've done 2 webinars previously regarding the Section 1135 webinars. On Monday, we did a deep dive into the requirements for the telehealth waiver. A recording of that webinar, along with the slides and a Q&A sheet, are available on PYA's COVID-19 hub for your reference, as well as the materials from Wednesday's webinar when we went into the traditional Section 1135 webinars. Today, we're going to try and provide more practical guidance on how to stand up a telehealth program in a relatively short period of time, addressing technological considerations, workflow and process issues for your practices, as well as how to engage your client, your patients as you move forward with telehealth. Just a couple of quick note follow-up on what's happened this week since we first talked about the telehealth waiver on Monday. First, we had several questions regarding whether you can provide telehealth services from your home. If you have a practitioner who's working from home, and can they provide the telehealth services? Today, CMS published a FAQ regarding provider enrollment, and included in that FAQ was a question on this issue. CMS's response was that it is permissible, but that the provider's home needs to be included in the enrollment information. Also, the other significant development this week, of course, is the Congress working on the CARES Act. That's the $2 trillion COVID-19 Relief Act. Included in there are 3 relevant telehealth provisions. First, permitting rural health clinics and federally qualified health centers to bill for telehealth services. And second, permitting new patients to receive services via telehealth. And third, permitting providers to waive copays and deductibles associated with telehealth. On that second and third point, CMS guidance had indicated that they would not enforce those provisions, but now we'll have clear legislative directives. So just some updates on what's been going forward. But I want to introduce you now to my colleague, Barry Mathis, who's joining us from his home office in Knoxville, Tennessee, to address some of these technological considerations.
Thank you, Marty. Appreciate the introduction. If you want to reach any of the resources that we currently have out there, the things that Marty had just described for you, some of the things that we're going to talk about during the webinar, you'll see there some resources. I recommend you go out to the PYA Hub. We update that daily, it seems like, or even hourly in some cases. It's a fast-moving process that's going on right now, and we are doing everything we can to keep up. And the people following me, I promise you, are the experts in this field. I'm the technology guy. I'm likely the only one that knows what a client server versus a cloud-based really means. So I'm going to go over some of that information with you because I've been getting a ton of phone calls from providers, hospitals, security folks, compliance folks, even my family on what this whole telehealth thing is and how they can get it and is it necessary, these sort of things. So if we'll advance. First things first, the number one question that I get since this all started was how quickly can I implement some type of telehealth solution? And it really has come down to two or three different buckets. The main two are in a conversation. It seems like they're really just wanting something to help triage patients, coordinate patients. It's not a clinical visit. It's not a physician talking to a patient. It's not advisory in that state. For those situations, you are still fine to use your telephone. Some of you are likely already doing that. However, you need to be aware that CPT code G2012, if it comes to that virtual check-in to where there is some type of clinical provision in there, you're giving it clinical advisory, then it may be a virtual check-in. And to get paid for that, you're going to have to follow those guidelines. So be careful on that. Clearly, if it meets a face-to-face visit, if it is something you're wanting to get paid for from Medicare, reimburse for that, and it falls within that telehealth services clearly defined by Medicare, then the video has to be in there. It cannot just be a telephone call. And that has been a source of confusion, even for me as a techno guy. The people following me on this webinar had to clear me up on that, so I know what it feels like with everything that's going on there. So don't feel like you're left out if you just don't understand. We want to help in this seminar to get that to you. Go ahead, Matthew. So if you're using a personal device, this one has also come up just recently. Barry, one of the things, because I'm a security guy, I'm concerned about my staff security. We understand the relaxation of where we can provide these services, and we have clinicians and even admin and home staff or office staff that are working from other locations, but they're calling our patients, and the only thing they can use is their home phones. We recommend that you use a mobile phone and use something like Doximity or any type of a dialer. What these applications do, it masks your phone number. It's the same type of technology and application that the guy going to sell you a new warranty on your Chevy calls, and it looks like he's calling right down the road in the next neighborhood because it looks just like your phone number. Lo and behold, it is not from your neighborhood. He's just masking his phone number. Same thing. What you want to do is take that phone number from your office and mask your home phone with that. So when you call that patient, whether it's in a clinical setting, even a Skype setting or a FaceTime setting, you can use that number to mask that office. So it looks like it's coming from the office. It looks as though you're still operating out of the office. One of the things that you may see is the patient even feels better. It doesn't look like it's coming from somebody's house. It looks more professional. It certainly goes to making the patient feel better about that visit. If you are in your facility, by all means, you're still going to use your telephone systems. The next thing is, several times this week, I've had the conversation with physician providers, clinics, and even hospitals. Yes, there are a lot of relaxed things you can do around video conferencing and still get paid in a face-to-face telemedicine situation or telehealth situation. The question is, should you? Just because you can doesn't necessarily mean you should. So some of the advice that I've been giving is there's a lot of systems out there that are HIPAA compliant, GDPR compliant. They're set up and they're very fast ramping those up. And they're not tremendously expensive, some even offering a lot of free trial situations. So all of these, and many of these in most cases, can even be used after you've gotten through this to continue as your go forward telehealth strategy, which we'll talk about later in this webinar. So consider this before you run out and develop and just say, let's start using FaceTime, let's start using Skype. In certain situations, you don't have a choice. It's just put you against a wall. You've got to do it. We get that. But we would say, sit back and look at your situation and say, what are you going to do in the future? What process are you going to create? Would it be better to at least reach out to some of these folks and see if you could stand something up very quickly that also helps you down the road? Now, there are hundreds of telehealth solutions out there. I attend HIMSS, which is the Healthcare Information Management Systems Society. I've attended over 22 or 23 of those, and it seems like every year there's new telehealth systems. It's people coming up with startup companies. It's existing companies coming up with something new. and there's just tons and tons to choose from. So please do not take this slide as these are the absolute ones you need to choose. These are some that others have recommended. I've vetted them out a bit. I've checked into that, considering a few factors. One, what's your population? How difficult it is for those patients? Are they senior patients? Are they college students? Who's likely going to be? Is it a cradle to grave? Is it a therapy system? Is it, some type of physical therapy or psychological therapy? All these kind of things. What specifically is going on? Is there a telehealth that helps you in that versus just any old telehealth that's out there? The first one you see there, which was interesting to me, and we have a client using this now. Many people remember back when CMS released the guidance around texting, encrypted texting in hospitals. One of the companies that emerged out of that was a very popular company was TigerText. Well, TigerText actually has a telehealth solution called Tiger Connect. And if you are already using TigerText, and I know a lot of physician practices are, I would reach out to them and say, how much more difficult and costly would it be to simply add on the Tiger Connect and get the training online and get this started up? Likely one of the fastest things you can do. If you're already a Tiger TeXt client, being a Tiger Connect client is not that far away. Okay. The Vivify Health, it's very nice. It's included with a lot of caregiver visits specific to types of patients and intakes, much like you would your EMR. It is fairly inexpensive. It's not one of the cheapest that are out there. There are some free trials with that. It is very slick, very professional, and it boasts a very quick startup time. So, maybe take a look at that one. If you're one of those therapies that I talked about, and maybe, the Tiger Connect or, DocMD or WebMD, something like that doesn't really meet your needs, there is one out there called TheraNest. Now, it is really geared towards therapy type institutions or therapy type clinics. So take a look at that. It is not terribly expensive. Again, most of these that I have on here are somewhat affordable. TheraNest is robust. I would say what TheraNest does better than some is it has a lot of aftercare interoperability connections in with your EMR should you want to do that later. VC, one of the simplest, basics, easy to start up that I've seen in a long time. It boasts about from 10 minutes of contacting them, you can be seeing a patient. That's their claim. So, multiply that a few factors. But I went through the process myself. I took a look at it, and it is something that if I had an aging population and if I was mostly geriatric care, something like that, and aftercare visits, VC is definitely one that I would look at. DoxyMe, it's kind of along with the next one there, which is Men in My Family. You just see it's men there. It's called Men in My Family. These two together, these are if you're cradle to grave physician practices, family services, they have just a little bit of everything embedded with them. They're not that expensive. The Men in My Family, the one there on the bottom right, they boast a 99.85% connectivity ratio, which is very good because that's one of the things that you're going to be concerned about as you choose some type of it reflects on your office. It slows things down. It bogs up the system if you spend most of your time simply trying to stay connected. So pay attention to that when you are choosing your provider or your solution with this, because it can make a big difference. But these are just 6 that I've taken some time over the last couple of days and made some phone calls and went out and looked at some reviews. And this may be where you start. You may go from here. You may already have your favorite. You may already be in one now, and you're trying to figure out what's the best way to use it. And believe me, the people coming behind me are going to help you with that. These next are after a conversation with a couple of small practices and singles. They're like, Barry, I want to use it, but likely when this is over, I'm just not ready for a full-blown telehealth strategy, and I respect that. Certainly not trying to talk somebody into that. So these are 6 of them that I found out there that are they're almost free. In some cases, they actually are free. You stand them up, you use them, and if you're not going to use any of the other services like home monitoring, things like that associated with their analytics, then you can use it as just your telehealth visit information. It has the ability to collect documentation as long as you're not trying to create interoperability with your in-practice EMRs and things like that. Then these are likely some that would give you very quick stand up and almost no money and I would consider those for just that purpose. So what happens tomorrow? Right now, flattening the curve for the COVID-19, it's created this necessity, as we'll say, to strongly consider the telehealth in your practice or in your clinic. But it really should be based on more, and you'll hear me say that again and again. I wouldn't just jump into it simply because you can. As you're picking your telehealth system, and it doesn't take long to ask these questions. In fact, you can kind of cut and paste these and send them right to some of these vendors, but you should consider, what's the connectivity? Does it work for the college student the same way that it works for my mother, who's 74 years old? Does it provide for apps? There's several telehealth systems out there. They're very good and they're very inexpensive, but you really have to go to a web page. It's the only way to get it. That's just the way that they're written. They've not conformed or upgraded into some of the more modern, what we call HTML5 coding, which allows them to go from tablets to cell phones and apps and things like that. So check that out as well. Does it provide integration? You may at some point want to integrate in, or somebody may want to integrate in with you to make it easier for you to transfer information back and forth that you have captured inside your telehealth application. Does it integrate with those EMRs? Ask that question. Does it interact with in-home monitoring? Some of those that I showed you on that first page, those first 6, some of those have some very good in-home monitoring peripherals that come with that. So you can monitor the patients through the telehealth. It is literally getting right down to telemedicine and those virtual visits. Does it support multiple languages? This one came up 2 days ago. Hey, Barry, what are the telehealth systems? Do any of them offer a quick launch out to an interpreter, these sort of things? And there are some that do, and there are lots that don't. There should be more of those, it's sadly to say, but that's one of the questions. If that's where your practice is, if that's where your demographic is, you want to consider that before you start installing that telehealth system or certainly paying for it. And does it meet your state and your federal, your HIPAA and your ADA compliance requirements? Keep in mind that just because you meet the HIPAA doesn't necessarily mean you meet your state. You need to know that as well. And in a lot of cases, depending on what you're delivering, you may also have to meet the American Disabilities Act compliance. So the landscape beyond 2020, this is what's fascinating to me. And I went out and did some research and sharing this, and I was even surprised. I expected it to be a jump. I had no idea it was going to be this big of a jump. Before the pandemic started, 1 in 10 patients, according to a J.D. Power survey from 2019, were actually a consumer of telehealth. Since this all started, I contacted one very prominent telehealth provider and said, can you share, and they even posted this information as well, and they said 70% since the virus, and they give me a different dates on when it hit, but we'll say since January, 70% since the virus hit, and then 158% nationwide, and then in Washington State, they saw a 650% increase in their products. So people are reaching out for the telehealth. And I think the fact that telehealth is now cloud-based, you don't have to download software. Virtually every one of those that I talked to you about just a minute ago, you don't have to download any software. You just have the app, or you go to the website, and everything's there. There's nothing, a server you have to load or anything like that. It makes it very easy to stand up inside your practice. Beyond 2020, it is said that the necessity is the mother of invention, and fewer events fuel necessity more than a disaster. I wrote that last night and put it on the slide, and I truly believe that. If you look back in history, there's a lot of innovation that's come because we had to do it. We didn't have a choice. And then you may be in that very case right now. Since the COVID-19 pandemic has come out, those resources that likely you didn't know about are now top of mind for you, and that's because you're really in a have-to situation. So it's likely that in this whole pandemic that's going on, there's a lot of first-time telehealth consumers that are possibly going to get their first taste of this. And I know of one personally, and the response was, I had no idea that you could do this. I had no idea that you could talk to a physician and do this through the phone and then look at me and, oh yeah, and this happened to be in a case where they already had a telehealth system. But I don't think that's going to go away, okay? I honestly believe that consumers, like we do with many things, that once we get a taste of it, all of a sudden we want to be in the driver's seat. We start demanding of the manufacturers and the creators that, look, I have specific needs. Can you please create something for me? And that just has not existed in the telehealth community until this point. So I'm excited about that. If there's any type of positivity that can come out of something like this, besides just bringing people together to work together, a technological jump in how we use telehealth, I predict is going to happen. I'll share one thing with you, then I'm going to turn this over to Valerie, my colleague. One of the examples that I have with, as you consider your telehealth product, test those out. You don't have to get completely installed and in bed with this and then find out, oh, this doesn't work well. Test those out. Specifically, if you're going to use a service that's now been allowed through the relaxation from CMS. If you're going to use a Skype or a Facebook or a Google Meetup, likely some of you don't even know what Google Meetup is, so don't jump out to that if your patients likely don't know what it is. I myself called my mother and said, hey, Mom, if I was your doctor right now and I wanted to see you face to face, do you know how to do that? And the answer is no. And I said, well, just click the little camera on your phone. And within just a few seconds, I was looking up my mother's nose. And we could have had a conversation. I could have instructed her otherwise, but some of these technologies are easier to use than others. So I'll thank you for my time with you in this webinar. I'll hang around for questions, but I encourage you to think before you leap. But certainly, if you leap, pay attention to the regulations. Valerie?
Actually, Barry, this is Kathy. I'm going to take the next section if I can.
Oh, I'm sorry, Kathy. Yeah. My apologies. Kathy is next.
My comments relate to your mother's nose, but a little bit more broadly. So I would like to spend a few minutes. I'd like to spend a few minutes talking about telehealth from the experience of the patient, and also do a commercial for what my colleague Marty Ross talked about at the opening. She and I did a webinar on Monday that went into the details of the new CMS guidance with regard to telehealth, specifically talking about the elements of the waiver. Two items were waived in response to this crisis. Both of those items really impact the patient and who providers can now reach and where they can reach patients. So that's what I would like to go through. But this slide talks about before the waiver, before the world changed so much, what the general rule has been for telehealth. The general rule has been that the patient has to be physically present at a healthcare facility when they're providing or interacting with the provider through telehealth. And those facilities I have on the slide, they're called eligible origination sites, and they're healthcare facilities. And keep in mind that the purpose historically, no, keep on this prior slide, go back, Matt, if you go back one slide, keep in mind that the purpose of this historically has been to allow people living in rural areas, people in Medicare in rural areas, to have access to professionals who are not in their community. That's why you see this list of this particular mix of entities where the patient had to go. So the patient could go, say, to the rural health clinic, and they could have a telehealth appointment with a specialist living in an urban area or in another rural community. But this really was requiring patients to travel, even within their small towns or communities, to one of these specific healthcare facilities. And this is what's changed. Okay, next slide. So currently, under the waiver that exists during the time of this crisis, the rural requirement is waived. So a doctor or provider can contact any Medicare patient anywhere that they live in an urban or rural setting. They don't have to limit this just to people living in rural communities. The other thing that's really significant is that the person on the other end, the patient, can have a telehealth appointment from their home. That telehealth services can be provided in all settings of care, including the patient's home. When you hear this described publicly, it will often be referred to as just this, a patient's home. But I wanted to kind of point out that older people and people on Medicare live in all kinds of dwellings. They're not just living in single family units. Patients live in apartment buildings. A lot of older people live in assisted living or the independent apartments in a continuous care retirement community. A lot of low-income older people live in senior high-rise housing, HUD housing. In those congregate settings, they have staff available who may be able to help facilitate a telehealth visit by assisting the patient. And there will be some patients who need some help. Barry was able to accomplish this with his mother fairly quickly, but there may be some patients who need some help getting this set up. And for people living in congregate settings, they kind of have ready-made people to call upon who can assist them. That wouldn't have necessarily been the same opportunity before, because these patients had to go to a healthcare setting that we talked about in the prior slide. Next slide, please. So I've been looking at, what's the latest information that I can find about the attitude of older adults with regard to using technology. The most recent study I found was out of the University of Michigan. They did a poll last fall published this report on telehealth and older adults. And I think this is both helpful, but also has some warning signs. First of all, older people believe that the quality of an in-person visit is better than telehealth. 58% of people thought it's probably better if you see the doctor in person. But nearly half of people were interested in having a telehealth visit with their primary care provider. But there are some concerns. People are worried that the provider will not be able to do a physical exam. You can see that on this. They're worried that the quality of care won't be as good. Older people are worried about privacy. They're concerned about how hard it is to use the technology. 47% said they're concerned about difficulty. And also 39% are worried about seeing or hearing the provider. There are other surveys going way back for the past decade, and what they all point to are these last two most significant factors. How easy is it to use it, and how helpful will it be? So as you approach your patients about this new opportunity, I think it will be important to say why this is helpful to them, why it's helpful to you, and how they'll be able to use the technology to connect. Will it be easy enough for them to do? Next slide, please. I also think it's important to keep in mind that you shouldn't make assumptions about a patient's comfort with technology. Barry gave an example of his mother who's in her 70s, mine's in her 80s, and we've been using FaceTime for a long time. So you can't, even with people in advanced age, assume that they're not comfortable. There are 8 million people on Medicare who are there because they're less than 65 and they have a disability. The younger population may be more comfortable with technology, but the reason that group of people's on Medicare is that they have a disability, harkening back to Barry's caution about making sure we're compliant with the Americans with Disabilities Act. It's also really important to not exclude family caregivers as we move to this virtual technology, whether it's a telephone or certainly a visit that's visual. Family caregivers are really important members of a care team. These technologies can support connecting the person on Medicare and a family member, and actually may provide an opportunity to loop into the conversation family members who live at such a long distance that they're not normally in the conversation, but they would like to be. And like I said earlier, older people may need someone to help facilitate. This will be kind of a case-by-case basis. 10% of people on Medicare are older than 85. Half of people over 75 have a hearing loss. A lot of older people, millions of older people, have vision loss and cognitive impairments. I didn't put numbers on those because the data depends on kind of what specific impairment you're talking about. But there are many older people with cognitive impairment, either a disease like Alzheimer's or just old brains, just the cognitive decline that happens with advanced age. And I have a background in the field of aging and can tell you that we can serve people and help them be independent in their homes when they have quite a few functional impairments, and they can still live at home, and some of them live alone. So don't assume that someone's not impaired just because you reach them at home. They may actually be trying to make it work with quite a few challenges as they live independent. Next slide. A couple of things to think about before I turn this over. Just from my work with older people and my background, I think mobile phones are probably going to be the easiest way to connect. I think FaceTime has real promise. I understand everything Barry was talking about in terms of looking at your technology needs now and in the future, but I think mobile phones probably the easiest. If someone needs facilitation, it may be someone can walk around the senior high rise with a tablet or a laptop, set up a place that the person can come for facilitation. I've spent a lot of time working with older people and talking about exploitation and fraud and financial exploitation. And we really encourage people not to accept calls from unidentified numbers. Barry has pointed out that it would be helpful for the technology to reveal the doctor's office number. If you can't reach someone, I would make sure they know what number you're calling from so that they don't assume you're spam or someone unfamiliar. And finally, if you want to move to a position where, because of the telehealth technology, you will really ask that patients help do some of the monitoring at home, keep in mind that some people still don't have phones. Some people still have landlines, which is kind of amazing, but some people still have landlines. I have a colleague who does a lot of work with older people in their homes, and last week she said they're finding a lot of older people don't have thermometers. So that sort of basic monitoring with COVID-19 is essential, and you can't assume people have thermometers. So if you're going to move to relying on people to look for symptoms or signs and relay those to you, you should ask a lot of questions about what they have available and can they read it and see it if you're relying on them to do some monitoring at home. So thanks for participating. I will turn this over now to Valerie.
Thank you, Kathy. So for the rest of the presentation, we're going to be talking about the compliance related to telemedicine, related to coding, and also virtual and e-visits. But what you'll find is that there's going to have to be some continuity in the process that we're deploying within the physician practice so that you can actually work through the clinic flow. So that would probably start with the patient calling for medically necessary chief complaint. So they're calling, they actually need service, and then you're moving over to deciding whether that requires a patient consent. That Medicare does not require a patient consent for telemedicine, but there are other services in other states that require that patient consent. So you don't want to automatically have a blanket assumption that that patient consent is not required, but you also may decide that you don't want to have a blanket assumption that it's going to always be required for your practice. So deciding how you want to deploy those forms and how you want to obtain that information is going to be important. For example, the virtual visits require a verbal consent, which can be just documented in the record. So there's different ways to obtain that consent. So you want to make sure you're following those guidelines. And then the provider calls the patient if it's determined that that service can actually be a telemedicine visit, because that does need to be medically necessary and support standard of care for a telemedicine visit. So if that provider calls the patient, conducts that visit, and then documents all the service that was provided. And obviously, there's limitations to the service that can be provided. So within the EHR, you typically have a list of documentation already in front of the provider that's kind of a templated document that pulls out the full exam and a complete exam that would include palpation and other services that that would require the patient physically being present with the physician. So you want to make sure that that documentation is removed from the record and not included. So the physician is going to have to take time to edit that record. There's also options for transcription through some of the telehealth service options that Barry mentioned. And so if there is transcription performed during the service, then you'd want to make sure that that is also included into your EHR, whether that is scanned into your EHR, also reviewed by the physician and signed by the physician so that that can be supported as a billable service. Then you select the code based on the actual elements performed. And as I mentioned, that a full exam is not going to be able to be performed. So making sure that you limit the code based on the history, exam, and medical decision-making that is actually provided and medically necessary for that patient. And then submitting the claim with the appropriate modifiers in place of service. Now, the modifiers in place of service vary amongst the type of service you're providing, the state that's you're providing that within, and then the payer that you're providing that under. So the considerations that you want to think through for remote service will depend on the patient's presenting problems, their co-conditions that create additional risk if they're exposed to COVID, the patient's insurance payer, the state the provider is in, as well as the state the patient is in if that's different. So under the public health emergency, we're no longer limited to the patient being in a HIPS or a health professional shortage area. So the patient may be at home or a clinic or a hospital. So these services, again, have to be medically necessary and support the need for an audio-visual visit. Like Barry said, just because we can do it doesn't mean that necessarily that we should. And if the service is not warranted in the manner that you can provide it over audio-visual, if there's some limitations that would not allow you to provide a standard of care that's required for the presenting problem, then you probably want to look for a different means for serving that patient. Then another component I want to mention briefly is that the authorized distant site providers for telehealth include physicians, nurse practitioners, physician's assistants, nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals. The telehealth visits, when provided in the home, you would use the 99201 through 99215 for those services, even though they're at the home. You would not use the home site services. You still have access to the G codes that are relevant to consultation. So if you have a consultant at a distant site and the patient is at the originating site of an emergency department or in the inpatient hospital setting or in a SNF setting, you have these G codes to select from. You can advance to the next slide. And one thing to mention about telehealth is you do have the ability to waive the cost sharing for those services. For the modifiers for Medicare Telehealth, you're not required to use the CR or DR modifiers that have been submitted out. You've probably seen them on numerous occasions over the past week, but Medicare did send out another notice saying make sure you're not including the DR or CR on your telehealth services because they're not required. The GT and 95 modifiers are also not required for Medicare, but many of the private payers are requiring them. What you'll see is that when you're looking through your specific requirements for your commercial payers, that a lot of the information is coming out so rapidly and they're submitting out information so rapidly that there's little consistency amongst the payers. So what you may have to do for one within those modifiers is going to be different for another payer. So you likely want to get a list together for each of the states that you serve, for all the payers that you serve, and making sure that those modifiers are accurate for each of those payers. The place of service is no different. The place of service 02 is used for telehealth services provided to Medicare beneficiaries, but that's not always the case for other payers. So you want to make sure that you're providing the correct place of service for that payer. And then there's been a recent release, actually, as of today, where we've gotten clarification, as Marty said, in regards to the location. If the physician is at home, then the physician needs to be credentialed, and so you can call your Medicare administrative contractor and immediately get that home location enrolled. So they're trying to make this as swift as possible. Okay, Matthew, you can advance. So for the Medicare telehealth visits, we are allowed to serve both new and established patients. There's still in the requirements, you'll see that there's a established patient requirement within the guidelines, but they are not planning to audit for that. And then we do anticipate that will be completely allowed through the CARES Act. The services that you might include are surgical follow-up, routine reviews, and sick visits, but I'll reiterate again that these services that are provided need to be medically necessary and appropriate for the type of care you're providing. If there's any elements of a certain service that require a face-to-face visit in the sense of physically face-to-face, then I would not do those services. In addition, Medicare still has their telehealth list that you can reference on their website. If a non-physician practitioner is providing the telehealth service, make sure you're billing under their own number. This is not something that you would be doing incident to. If the NPP is at their home and providing the service to someone at their home, then there would be no incident to allowances there. So if the NPP is not credentialed, there are temporary credentialing applications available now that are swiftly being approved. So you can obtain that temporary credentialing application, get that completed, and then do a standard one at a later date. So make sure you're documenting your history and your exam elements, any type of diagnoses that are being managed during that visit, and making sure that code level is appropriate. So if you're seeing a new patient, you would expect that code level, because of the lesser exam that you're able to do, to be something in the neighborhood of a 99201 to a 99202, because it'd be very difficult to get a lot of exam elements within that service. And then if you're utilizing a telescribe, make sure there's actually some services that allow you, telehealth services allow you to use a telescribe. So make sure that you're reviewing that documentation for accuracy, and then have the physician or NPP sign the record for that to be a supported service. So in the next slide, wanted to show you this because this is specifically from West Virginia, their documentation requirements, and this gives you a sense of what people will be looking for when we're producing documentation in an audit. So this slide and the next slide include some tips of what we would recommend that be included, like the identity and location of the patient, confirmation of the identity and qualifications of the physician, the physical location and contact information of the physician-patient relationship, is it established or new? Is the telemedicine technology that you're using appropriate for the patient's presentation? I would actually document that clearly in the record. And then if there is consent required, that if it's a verbal consent, that's documented in the record, or if you obtained written consent, I would make a quick statement that was obtained. And then consistent with the service is consistent with traditional standards of care for the patient's presentation, and that the documentation justifies the course of treatment, meaning tells the story on why you're actually treating the patient the way you are given the circumstances. The next slide. So for Minnesota, some additional documentation aspects that they've included is the time the service began and the time the service ended. So supporting that time amount will also help support that level of code. And then the mode of transmission, were you on Skype, were you on FaceTime, were you using some other service, what service was that, the location of the originating site and distance site again, and then if you are obtaining a consultation through a distance site provider from a hospital's perspective, making sure that consult documentation is in the record. Move on to the next slide. So then the next information is in regards to virtual check-ins and e-visits. And remember that these virtual check-ins and e-visits are not telehealth, and they do not have to follow the same guidelines as telehealth. So when you're looking at these services, know that they're subject to copay and deductible, but during the public health emergency, the fees can be waived. The OIG has put out information that they're not going to put any AKS or any kickback statute liability against the provider if you waive those fees. So they want to make sure that there's appropriate access to care. And then the virtual check-ins can be via telephone or patient portal, for example. And then the communication must be related to the medical visit within the past 7 days and must not lead to the medical visit within the next 24 hours. So if the physician is speaking with the patient over the phone and decides to bring the patient into the clinic to see the patient within the next 24 hours or at the next available visit, then they would not be billing for this service. This service is obviously based on time, so make sure you're documenting the time as well. And then you'll want to document the verbal consent, because the verbal consent is required to document that in the medical record. You do not have to obtain that verbal consent at every visit. You just have to obtain it once for the year, and then bill the place of service for based on where the provider is located. Next slide. So e-visits are a communication with the patient using the patient portal or secure email, for instance. The codes are based on time and capture the time spent for up to 7 days. The codes 99421 through 99423 can be billed by physicians, PAs, and NPs, basically those providers that can bill for E&M services. And then the G codes allow for you to bill for those qualified non-physician health care providers that cannot bill for E&M services, such as physical therapists, occupational therapists, nutritionists, and social workers. And there are CPT codes for those visits that correspond with those G codes as well, to make sure that you know which codes that the payer requires. The CPT codes are 98970 through 98972. Next slide. So after we get beyond this storm, we'll want to make sure that we're auditing to confirm that there was accuracy in the medical record. If there's any way that you can have some of the teams making sure that the physicians are documenting appropriately early as they adopt this new technology, monitoring for those to be accurate, then that would be wise. But I know you're moving fast and furious right now and may not be able to do that. We are hoping that we'll have some type of leniency from the government for this time period from a documentation perspective, but we also know that there's bad actors out there that have already been taking advantage of our seniors and taking advantage of our patients. And so they are going to be auditing. What I would recommend, though, is if you do have a 2020 audit, that you basically demand that there's a stratification of the services during this emergency period and non-emergency period, because we do expect a higher level of documentation errors during this time period and don't want that stratified across the entirety of 2020. So with that, I'll turn it back over to Marty.
Excellent. Thanks, Valerie. Sorry, a little user error trying to find the unmute button on the website here. First of all, just to remind everyone that all registrants will receive an email tomorrow that will include a link to the recorded website as well as a link for you to access the slides. We will then subsequently add the transcript for this webinar, as well as our written Q&A responses. But we're going to take the next 10 minutes here and work our way through the Q&A that we've received via the screenshots. I'll try and take a first swing at some of these, but Valerie, Kathy, and Barry, please jump in with any qualifications or some additional thoughts. First of all, as a question about consent, and our attendee asks, how do we have consent forms signed if we're providing telehealth services for a new patient? And just to clarify, neither the telehealth services nor the virtual services require that the patient sign a consent form. Instead, the virtual services require that the patient give oral consent, which is then documented in the record. Now, this does raise the question of how one shares required documentation with a new patient where the first communication is via telehealth. Today, in fact, CMS just published an MLN Matters email that addressed the question of sharing documentation in a hospital. And it goes to providing those documents to an individual who either has been diagnosed with COVID-19 or suspected to have COVID-19. But in that response, CMS highlighted that it may be possible to email documents to an appropriate address. And that, extrapolating from that guidance from CMS, you are doing a new patient visit via telehealth, and be sure that you secure an address to which you can forward the required documentation, such as, for example, the notice of privacy practices. Again, if you are going to take on new patients via telehealth, be sure that that is also part of your process. Valerie, anything to add on that from a coding and documentation standpoint?
Yeah, I think that's the primary method that we've heard is email. Even we've heard actually where someone was just responding as approved, that they're approving that that they agree to doing a telehealth visit as consent, just stating their approval versus a signature.
Great, thank you.
Marty, this
Yep.
is Kathy.
Yep.
Rather than me sitting here looking at my picture, can we go back to the COVID-19 PYA slide so people listening have access to that information where we put so many of these resources?
Nothing like looking at our own pictures.
Yeah.
I
That's
got my picture not included on this set. So.
Okay, lucky. But if we could put that one back up, I thought it was a helpful resource for people.
Yeah, Matthew, if we can go back up to that COVID hub slide, it was right after the agenda, that'd be great. Excellent. So next question we had asked for written resources with regard to rural health clinic and federally qualified health center coverage for telehealth. Now, unfortunately, we're in a no man's land right now because the relevant provision is within the CARES Act, that the $2 trillion relief package that passed the Senate last night. It is up for vote the House tomorrow. But just to provide background and context here, Congress added the telehealth benefit to Medicare back in 2001 via Section 1834M of the Social Security Act. And in that, it narrowly defined the benefit to include only professional services that are billed on the Medicare physician fee schedule. It also included the geographic and location restrictions as well, but focus here, it's limited to those practitioners that bill on the Medicare physician fee schedule. So to this point, there has not been a vehicle for a rural health clinic or an FQHC to receive reimbursement for telehealth services where the practitioner is present at an RHC or an FQHC. Now, to date, one workaround has been similar to how physicians or non-physician practitioners that are based in RHCs or FQHCs provide services in an emergency department. Or if you have a reassignment under COB Method 2 billing, that has also been a vehicle potentially capture this reimbursement. That, of course, is not the optimal way to provide this service, and thus Congress has included this provision in this pending legislation that directs CMS to create RHC and FQHC reimbursement for telehealth services. Assuming that legislation is approved by the House tomorrow, signed by the President, still means we have to wait for CMS to do the work it's assigned in that legislation and create a fee schedule, codes to be billed and the like. But most likely, this is going to be retroactive back to the date on which the benefit was created. So we are likely to see you'll be able to bill for services being provided now, but we're going to pay really close attention to it, and we'll have those resources available on the COVID-19 hub as more information becomes available. On Tuesday, CMS Administrator Seema Verma participated in a CMS telephone conference. The question did come up about RHC, FQHC coverage for telehealth, and she indicated they were well aware of the issue and working on it. So hopefully it'll be a very quick turnaround once the CARES Act is approved. Next question concerned how do we identify whether there are behavioral health services that are reimbursable as telehealth? And here we'll refer you to the COVID-19 hub, which includes a link to the calendar year 2020 CMS approved telehealth codes. Again, referring back to Section 1834M in the Social Security Act, one of those requirements for telehealth is that the service has to be approved by CMS as appropriate for reimbursement for telehealth. So each year, CMS publishes a list by CPT code, HCPCS codes. For 2020, there are exactly 100 identified services, several of which are behavioral health services. So you'll need to go to that list, identify the appropriate code. Next question we had is, when you submit claims for telehealth services, you include both the E&M code and the telehealth code. To clarify here, again, in reference to that list of telehealth reimbursable services, you will find there are specific E&M codes, sort of the full range of E&M services are included on that list. There is no separate telehealth code. Instead, you bill with place of service 02. CMS about 3 or 4 years ago replaced the modifiers in the Medicare program, at least, with instead billing for telehealth services designated by place of service 02. Again, Valerie, you want to highlight the differences for commercial and Medicaid payers?
Yes, well, it varies nearly by everyone, but most of them are allowing the E&M services to be billed for the home setting, and then you would just bill that along with whatever modifiers they require. Some of them are requiring the CR along with the 95 modifier, et cetera. So it's primarily the E&M services. There's no additional code that you would bill in addition to that, because you're just billing for the professional service.
Great, thank you, Valerie. In fact, this next question is right up your alley as well. When documenting time, is the time based on the time the physician spends on the video phone with the patient, or should it include the other time preparing for the visit and generating documentation?
Well, you might want to document both, but I would document them distinctly, because I think that there's potential that you could consider, and I haven't seen this written anywhere, but that you could consider this telehealth service as a face-to-face visit and therefore allowed to bill based on time, because it is a face-to-face visit, because the intention of face-to-face is that you're interacting with the patient, not just doing paperwork or preparing for something or reviewing records and things like that. So I would document the face-to-face, virtually face-to-face visit uniquely. But Marty, have you seen anything in regards to that? I have not seen it explicitly stated that it's going to be allowed that we can use time.
No, I have not. Now, the virtual check-in code is 5 to 10 minutes. The guidance on that includes both the time speaking with the patient and any immediate follow-up. That's how it was described in the 2019 schedule. But no, I haven't seen it otherwise. Kathy and Barry, you can argue over who gets to answer this one. Is there any guidance on how to provide interpreter services when delivering telehealth visits? Typically, family members can't serve as interpreters. Is there any relaxation on this requirement here?
This is Barry. I haven't seen anything, to borrow a phrase from Valerie, written down for that. Again, whatever service that you're currently using, as far as just a telephonic service, I do know of some providers that are simply relying on that portion of it. So you may have a face-to-face conversation going in a telehealth situation, and on the speaker or connected to that may be your normal telephonic interpreting service. But I haven't seen any specific guidance on that, but Kathy can weigh in if she has. I can certainly do some research and follow up for you.
No, thanks for looping me in, but no, I haven't.
Barry, when you discuss these technologies, do some of them have the capability of creating a three-way conversation?
Yeah, in fact, a few of those that I mentioned on those 6, that was one of my requirements for those. Most of them have a way to create a three-way, and some it's very like VC, for example. It's very integrated into the product to where it's, if you want to identify ahead of time via the phone number who maybe a care provider is. So if I'm a care provider for my mother, I can already be in the system for that, so it kind of rings us up at the same time. Some of them are a little more rudimentary, so just like your FaceTime, you can always add a person into the conversation. So that's what you want to look out for. They're all going to say they can do it, but what I would tell you is make the distinction between they can or it was actually baked into the design that makes it easy for you to do.
Great, thanks, Barry. Unfortunately, there are a number of questions we are not going to be able to address here in the webinar, but again, we will follow up with a written Q&A document. Please, if you can, join us next Monday at 1 p.m. Eastern. We'll be doing our first webinar, doing the deep dive into the CARES Act, particularly focused on the assistance being made available to hospitals and other providers, as well as the Small Business Administration loans that are really going to be a bridge for many smaller physician practices during this COVID-19 pandemic. Again, thanks everyone for participating. As you sign out, there'll be a small survey. If you complete that, we really appreciate it. And otherwise, have a great day.
Thanks to our presenters, Marty Ross, Valerie Rock, Barry Mathis, and Kathy Greenlee. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to PYA Insights. On behalf of PYA, thank you for joining us and have a great rest of your day.